Good evening to all. Today my presentation is on normal coagulation with a note on coagulopathy and hemorrhage. Okay, we'll be dividing this topic into three parts: the mechanism of normal coagulation, tests and investigations to monitor the coagulation in the patient, and a short note on coagulopathies, which are disorders of diminished coagulation capability, which will be in case of bleeding disorders where there is increased bleeding, that is less coagulation capability of the blood, and cases in case where there is increased coagulation, that is a case of thrombosis. So hemostasis is defined as the arrest of hemorrhage. It is an integrated response by the blood cells, vascular endothelium, and extravascular tissue so as to attenuate the blood loss from the site of vascular trauma. It is divided broadly into four parts: vasospasm, platelet plug formation, coagulation and clot stabilization, and finally clot remodeling and fibrinolysis. However, in vivo, we have these four stages which overlap each other, and they form a continuous network. So the first stage is vasospasm. Vascular spasm reduces the outflow of blood from the site of injury. It is a sympathetic reflex which is triggered by the injured smooth muscle in the tunica media. It is the vasoconstrictors which are released by the endothelium, that is endothelin, and which are released from the platelets, thromboxane A2 and serotonin, are the vasoconstrictors which cause the vasospasm to occur in the vessel. There are various factors that affect the vasospasm and whether it is a clean cut vessel which when it contracts closes off the vessel and decreases blood loss. In contrast to this, a partially cut vessel, a crushed or a lacerated vessel will go into spasm in an uneven or an unequal form, hence which could increase the diameter of the laceration and cause increased bleeding. Any concomitant tissue damage in the form of muscles, fascia, or bone, that is fractures, can also affect vasospasm. Since these can cause lacerations, also the muscles which are cut can go into a muscular contraction which can also cut off the blood circulation into the affected artery, and hence decrease the hemorrhage. And also which type of vessel has been injured. Veins are more compressible but have a less tendency to go into spasm because of less muscle fibers present in the vessel wall. Yeah. We come to the second stage, which is platelet plug formation. Here we can see that I'll be describing it in the following slides. But however, what you can see is at the in the direction of blood flow, first we have the platelet deposition onto the injured endothelium, which is triggered by von Willebrand fracture. Von Willebrand factor. I'm sorry. This releases platelet fibrinogen molecules from the granules, which trigger platelet activation. The platelets activate and form causes a morphological change in the platelets, which help them to adhere to each other. On top of these activated platelets, the coagulation cascade is initiated, on which even more platelets are deposited to form a clot. So when we come to a platelet plug formation, it is the addition of activated platelets to the injured vessel wall. Normally, an undamaged endothelium expresses multiple inhibitory molecules which prevent the platelets to adhere and keep them in the normal laminar blood circulation. These molecules are nitric oxide, prostacyclin, that is PGI2, and endothelial ADPase, that is adenosine diphosphatase. It has got three substages, that is platelet adherence, platelet activation, and platelet aggregation. When there is an endothelial injury, the subendothelial collagen, that is the extracellular matrix, is exposed, which releases von Willebrand fracture factor, which is expressed in the collagen. This produces the conformational and morphological change in the platelets, which is seen over here. The von Willebrand factor, which is expressed in the subendothelial tissues, is used to activates the platelets and causes them to change their structure. This causes them to develop adhesive filaments and extensions on the surface, which help them to adhere to each other. These activated platelets release various molecules such as ADP, von Willebrand factor, again, which is present in the platelets also, thromboxane A2, vascular endothelial growth factor, and serotonin. Hence, this forms a positive feedback loop, which activates even more platelets and causes them to bind into the forming clot. Platelets ultimately bind to von Willebrand factor and fibrinogen, which in turn adhere and anchor to the damaged endothelium, and this forms a meshwork on which the clot forms. Now we come to coagulation. This is a schematic diagram of the coagulation pathway, which I will be breaking up and describing in the following slides. We have the intrinsic and the extrinsic pathway, which together combine at the level of factor 10 the conversion of prothrombin to thrombin to form the common pathway. We have the various coagulation factors. Total of 13 have been described by coagulation factors. The most common and the most important ones are factor 1, which is fibrinogen, 2, prothrombin, the factor 4 is calcium, factor 5 is proaccelerin, which is secreted by the endothelium. Then we have factor 8, which is an antihemophilic, that is factor 9, which is called Christmas factor, and we have factor 10, 11, and 12, which are present in the intrinsic pathway. Factor 13 is a fibrin stabilizing factor, which helps the fibrin clot to stabilize and to polymerize, which I will be coming to in the next few slides. We have the next few clotting factors, which have now been named from 14 to 20. Factor 14 is the prekallikrein factor, which is a precursor of kallikrein. Then we have the high molecular weight kallikrein Fitzgerald factor, which is a cofactor in the activation of factor 14. Von Willebrand factor has now been renamed as factor 16. Factor 17 is now antithrombin 3, which is also called antithrombin. This is an inhibitory coagulation factor. Heparin cofactor 2 is also an inhibitory factor in coagulation, which inhibits the activated factor 2A, that is which inhibits thrombin. And factor 19 and 20 are now been also known as protein C and protein S respectively. So we have a number of procoagulant proteins and a number of anticoagulant proteins. As you can see, the number of procoagulant proteins are much more than the anticoagulant protein. It is a balance of this that creates the normal blood flow within the vessels. In case of thrombosis, the procoagulant protein action is unopposed. And in case of bleeding diathesis, we have an anticoagulant action which predominates. Coming to the different types of factors, they are divided into the following types. The first type, the most common ones, are vitamin K dependent factors. All of these are synthesized in the liver, and vitamin K is required in the synthesis of these factors. They are procoagulant factors of factor 2, 7, 9, and 10, and the anticoagulant factors, which are vitamin K dependent, are protein C, protein S, and protein Z. Except for protein C and protein Z, all the other factors are serine proteases if you look at it in the molecular biology. Vitamin K, in the manner of synthesizing of these factors, vitamin K is a cofactor in a cyclic redox reaction in the hepatocytes. It converts the 9 to 13, that is in the amino acid, the amino acids from 9 to 13 on the amino terminal glutamate residues are converted into carboxyglutamate residues. Basically, what happens is this enables their interaction with factor 4, that is with calcium and the cell membranes, and activates them. So in absence of vitamin K, you will have a decreased, or in case of vitamin K antagonist, that is warfarin, acetrom, coumadins, basically, what we will have is these factors, there is a deficiency of these factors, and hence we have an anticoagulant effect. Coming to the next factor, that is factor 5. It is a single large chain glycoprotein present in the plasma and in the platelet alpha granules. This is activated by thrombin, that is activated factor 2, to form factor and this activated factor 5, which is denoted by a suffix of A, positively modulates the catalytic action of factor 10A. That means what happens is the activated factor A uh, increases the rate of activation of factor 10 to factor 10A by almost 10 to 100 fold, depending on the amount of tissue damage. This factor 5 is inactivated by protein C, which is an anticoagulant enzyme, by cleaving the molecule at the arginine bond. Now, since this is a factor 5 is a glycoprotein, we have a number of amino acids. If the protein C acts at the 506th point of arginine, it reduces the activity but does not completely deactivate it. And if it acts at factor 30 at arginine molecule at point number 306, the factor 5 is completely deactivated. Hence, we have come to what we have in factor 5 Leiden. This is a mutation where factor 5 where the arginine at 506 is actually replaced by glutamine. Hence, the inactivation of factor A that is reduced. So this causes a procoagulant state, since the factor 5 is the activated factor 5 is not able to be deactivated by protein C. Coming to factor 8, this is also present in plasma in association with the von Willebrand factor. This is cleaved by activated prothrombin, that is thrombin, and in this process it loses the von Willebrand binding site. This activates it once it is de-associated with von Willebrand factor. Factor 8 is a catalyst, that is, it enhances the activity of factor 9 and it is inactivated again by protein C. The deficiency of this causes hemophilia A, which I will be coming to later in the presentation. Now, these were all plasma-bound coagulation factors. Now we come to the factors of coagulation that are present within the cell. The first and the most important one is tissue factor. It is a transmembrane protein which is present on the platelets and the endothelium. This co-functions along with factor 7A and activates factor 9 and factor 10. It is released into the blood only in case of tissue injury or in inflammation, and it activates the extrinsic pathway. The second one is thrombomodulin. Thrombomodulin is again a glycoprotein which has a high affinity, which is actually a high affinity receptor for alpha thrombin. Now, once thrombin gets activated, it is divided in, it cleaves, the entire molecule is divided into alpha and beta and gamma subgroups. Now, alpha thrombin is a receptor, thrombomodulin is a receptor on the cell surface for the alpha subunit of thrombin. It has both anticoagulant as well as procoagulant, that is thrombotic activity. In the anticoagulant activity, that is the thrombin thrombomodulin complex acts as a cofactor for activation of protein C, which is itself an anticoagulant protein. And a thrombomodulin itself actually cleaves the TAFI, that is thrombin activable fibrinolysis inhibitor. This is a molecule which has got a fibrinolytic action into its active form. So what it does is it activates fibrinolysis and which releases fibrin degradation products into the system, which again causes a prothrombotic state. I'll be coming to this later in the presentation again. Coming to the extrinsic pathway of coagulation, we have studied this quite a bit of times, but we'll revisit this once more. An extrinsic pathway requires a contact with the tissue factors outside the vessel wall. Hence, it's called the extrinsic pathway. It occurs when there is trauma to the vessel wall, that is trauma and disruption of the endothelium. Tissue factor is released in this case, that is thromboplastin factor 3. Tissue factor is also known as factor 3. So this is released from the injured tissue and activates factor 7 to factor 7A. Factor 7A along with tissue factor together activate factor 10 to its activated form in the presence of calcium, that is factor 4. Now this activated factor 10 along with thrombin, activated factor 5, that is activated factor 10 and activated factor 5 form a prothrombin activator, which converts prothrombin to thrombin, and this is the extrinsic pathway. Now we come to the intrinsic pathway, which is present, which can be done in vivo as well. It does not need, it actually does not require an injury to the tissue cell. Only it does not require exposure to collagen. Disruption of the endothelium is more than enough, and this exposes the subendothelial collagen. This causes factor 12 to get activated to factor 12A in the presence of collagen. It requires the cofactors kinogen and kallikrein, which are the factors 14 and 15 to be present to activate. Factor 12A and then forms the cascade of activation in the line of factor 11, factor 9, and to factor 9, finally to factor 9 activated form. Factor 9A along with calcium and this thing and factor 8 activate factor 10 again, which goes into the common pathway, which converts prothrombin to thrombin. Now here we have a feedback loop where thrombin activates the prothrombin activator. This thrombin again can act on the intrinsic pathway, converting factor 8 to factor 10A, which has a positive feedback loop, onto the intrinsic pathway. So coming to the common pathway in short, what we have is prothrombin activator, which is formed in the extrinsic as well as the intrinsic pathway, will convert prothrombin to thrombin. And thrombin directly can convert even more thrombin and recruit more prothrombin molecules, and this forms a positive feedback. Thrombin also activates the factor 5 to factor 5A, which accelerates both the extrinsic and intrinsic pathways, which forms another positive feedback. Thrombin also converts, the main action of thrombin is to convert fibrinogen into the fibrin monomer molecule. Now fibrin monomers polymerize with each other to form loose fibrin strands, which get deposited onto the endothelium. Now multiple strands of these fibrin strands are modified by factor 13, that is the fibrin stabilizing factor, in the presence of calcium ions into a dense and tight fibrin threads, which forms a meshwork. It is onto this fibrin network that platelets get adhered and form the platelet, stable clot. What we have is once the platelets get trapped within this fibrin meshwork, they activate the fibril strands and they contract. Hence, the fibrin meshwork, which contracts along with the platelets, pull the edges of the damaged tissue closer. This forms two actions. This one squeezes the serum from the clot and dries and stabilizes it, and also causes the wound retraction where the vessel wall reapproximation can take place. Now we come to inhibitors of thrombus formation. The most common and the most important one is antithrombin, which used to be called antithrombin 3 in the past. It is again a serine protease glycoprotein, which inactivates thrombin and the activated factor 10, factor 9, factor 11, factor 12, kallikrein, that is factor 14, and high molecular weight kallikrein, that is factor 15. So it has multiple sites of action. It also has anti-proliferative, anti-angiogenic, and anti-inflammatory activities, which is more important in the setting of sepsis and disseminated intravascular coagulation, where we have sepsis and inflammation within the body in absence of antithrombin 3. So what we have, this is the basic molecule which is seen in antithrombin. It has a heparin binding site and it has a serine protease target site, that is at the 393 location. What we have is, this is where the protein binds to the various coagulation factors and deactivates them. Now heparin binding site, this is where heparin sulfate in the body, and where we have an anticoagulation where we have heparin. This binds to this site of the heparin domain and increases the action of antithrombin by up to 10,000 times. A congenital deficiency of antithrombin is an autosomal dominant inheritance pattern and causes partial expression of this antithrombin, which causes a prothrombotic state. The second most important one, inhibitory cofactor, is the tissue pathway factor inhibitor, that is TFPI. Since it is very bound to multiple lipoproteins in the plasma, it is also known as lipoprotein associated coagulation inhibitor. It has divided, the subdivisions of this glycoprotein are called Kunitz domains. So it has multiple Kunitz domains as seen over here. The Kunitz 1 domain, that is the proximal most part of the molecule, binds to factor 7A and deactivates it. The second part of the molecule can bind to factor 10A. The heparin binding site in case of TFPI is at the end of the molecule, in contrast to antithrombin where it is in the beginning of the molecule. But again, it cuts off the positive feedback in the intrinsic pathway. That is, deactivation of factor 7 and deactivation of factor 10 cuts off the extrinsic pathway from propagating. One of a minor cofactor, that is a heparin cofactor 2, is present in the blood, and it inhibits thrombin. Now this factor comes into play only when we are actually anticoagulating the patient with heparin or low molecular weight heparin. Otherwise, this does not have much of action in the body along with heparan sulfate, which is the anticoagulant present in vivo. So, but the activity of heparin cofactor 2 is increased once it binds with heparin. And it also has a hirudin-like region, which hirudin, as we know, is a injectable anticoagulant, which is a non-heparin type of anticoagulant. So we come to the role of platelets in coagulation. The platelets are storage reservoirs of factor 5, fibrinogen, that is factor 1, Wald-Willebrand factor, and platelet factor 4 and factor 11. An undisturbed platelet is non-thrombogenic in the circulation. Once we have an activation of the platelet due to tissue injury or due to addition of the platelet to the vessel wall, we get the von Willebrand site domain is exposed, and it is expressed from the granules out into the circulation. This von Willebrand factor, when it binds to the collagen, causes platelet addition to the vessel wall and activates thrombin. Now, thrombin is the most potent activator of platelets. So, platelets activating thrombin and thrombin activating platelets forms another positive feedback loop in the coagulation pathway. Once these platelet granules are released, the platelets adhere to each other and to the endothelium, and the subendothelial collagen. What we can see over here, multiple platelets bind to each other with the help of collagen and with the help of von Willebrand factor and form a clot. This is the unstable clot on which the fibrin of the coagulation pathway, fibrin polymers, once this is deposited onto this, it forms a stable clot. Coming to fibrinolysis. Now we have multiple coagulation factors. Once a fibrin clot is formed, persistence of fibrin within the body and within the vessel wall can lead to excessive thrombosis. So we have fibrinolytics which degrade the fibrin strands back into its degradation products. There are multiple factors which I will be describing in detail in the coming slides. The first and the most important fibrinolytic agent is plasminogen. This is a plasma protein which is cleaved by tissue plasminogen activator, that is TPA, and urokinase like plasminogen activator, that is UPA, into the active form, that is plasmin. Plasmin breaks up fibrin into its degradation products. The most common degradation product that we know of is D-dimer. The other fragments, the other degradation products are fragments X, Y, and E. These also can be monitored these also can be quantified in various tests, but they are not as important as the D-dimer. Plasminogen is activated in vivo by the tissue plasminogen activator and single chain urokinase like plasminogen activator, that is the SCU PA. Once plasmin is activated, it degrades into its lysine analogs, that is plasminogen splits into tranexamic acid and E-aminocaproic acid. These inhibit fibrinolysis as well, but these are the inhibitors of fibrinolysis in contrast to plasminogen. Since what happens is once these two molecules are formed, they retain the same binding sites as plasmin onto the fibrin. So they form a competitive inhibition of plasminogen in degradation of fibrin into its degradation products. Hence the use of tranexamic acid and E-aminocaproic acid in bleeding disorders. The direct plasmin inhibitors which are within the body are alpha-2 antiplasmin, alpha-2 macroglobin, and C1 esterase inhibitor. Tissue plasminogen activator is secreted by the endothelium in response to the thrombin, bradykinin, and shear stress on the vessel wall. It binds to the fibrin domains which catalyze the binding of plasmin at the same site. Now what happens is when tissue plasminogen activator and plasminogen together form a common molecule which can bind to fibrin, and this is and break it up into fibrin degradation products. Similarly, the urokinase plasminogen activator, which is also called urokinase, again activates the binding of fibrin. However, it is an independent activator. That is, it does not require to bind to fibrin to perform its activity. We have, like I said, the direct plasmin inhibitors are described here in this slide. We have alpha-2 antiplasmin. It is present in the plasma and in platelet alpha granules. Alpha-2 macroglobulin has 10% of the activity of alpha-2 plasmin synthesized by endothelial cells and macrophages. C1-INH, that is C1 esterase inhibitor, is part of the complement system, and it inhibits tissue plasminogen activator along with plasminogen. And we have in the normal circulatory circulation, we have plasminogen activator inhibitors, that is 1 and 2, which inhibit the plasminogen activators TPA and UPA. And as I had mentioned before, thrombin activated fibrinolysis inhibitor, that is TAFI, is expressed in the liver. It is present also in the platelets within the granules activated by thrombin. Now, activated TAFI cleaves the fibrin into its degradation. Fibrin, the binding sites for plasminogen. So what it does is it breaks up the fibrinogen into fibrin into its products which are still which can still contribute to coagulation. That is, the activity of this fibrin is not affected, but the cleavage sites and the degradation of fibrin by plasminogen is now inhibited by TAFI. We monitor coagulation by various coagulation assays. The most common of them are the PT, APTT, INR, and the thrombin time. That is the prothrombin time, activated thrombin, partial thromboplastin time. They are clinical assays of the onset of fibrin formation. So they are the advantages of these three tests are they are easy to perform and they give a report much more rapidly as compared to the other tests. And they are able to detect the deficiencies of the basic clotting factors in the extrinsic as well as in the intrinsic pathway. However, the disadvantage is majority of the thrombin that is formed is not measured by these assays. The minute the clot begins to form, the minute the thrombin is activated, that is when these tests show their report, show their result. Hence, 95% of the thrombin formation is not measured by these pathways. Coming to the prothrombin time and INR, that is the international normalized ratio, what it measures is the extrinsic pathway and the common pathway. Infusion of calcium and exogenous tissue factor and a lipid preparation, that is recombinant thromboplastin, to citrated plasma causes the extrinsic pathway to get activated. Hence, this activation of the extrinsic pathway converts prothrombin to thrombin and forms the clot. This is measured by the prothrombin time. In case of this test, the intrinsic pathway is negated due to the large amounts of tissue factor causing an overwhelming activation of the extrinsic pathway. It measures the levels and the action of factors 1, 2, 5, 7, and 10. The disadvantage of this test is mild deficiencies of these clotting factors can be missed, again because of the tissue factor present in high concentration. The activated partial thromboplastin time is performed by addition of phospholipids calcium, and a foreign surface, that is kaolin or silica, to citrated plasma in the absence of tissue factor to form a clot. Hence, where we don't have activation of tissue factor, it is only the intrinsic pathway that is activated, and again it measures the common pathway. It evaluates the factors 12, prekallikrein, that is factor 14, HMWK, that is factor 15, and also factors 11, 8 and 9, that is effectively the intrinsic pathway and the common pathway. It is very effective in diagnosing hemophilia A and hemophilia B, and to also it is a very accurate monitor of heparin therapy in anticoagulation. It also is able to detect the lupus anticoagulant. A conjunct of this test is the activated clotting time, which is an adjusted APTT test, which can evaluate heparin as well as direct thrombin inhibitors action. The thrombin time is used to measure only the common pathway, that is thrombin and fibrinogen activity. It detects direct inhibitors of the common pathway, that only these two factors. It is sensitive to the action of heparin, fibrin degradation products, and hypofibrinogenemia, that is or dysfibrinogenemia, that is the absence or the deficiency or the inactivity or deranged activity of factor 1 is measured by the thrombin time. It is useful in evaluating a prolonged PT or APTT value by discriminating between a thrombin generation and the inhibition of thrombin. That is, in case the activity of prothrombin to thrombin is affected, what we have is both the pathways will not be able to act will not be able to propagate a clot formation. Hence, a thrombin time is used for specific factor 2A deficiencies. We come to one of the most important tests in the present times, that is the thromboelastography. This test focuses on the viscoelastic changes in the whole blood, that is during the coagulation process, that is when the blood clot is being formed, the viscosity as well as the elastic properties of the blood keeps changing over a period of time. This is measured by thromboelastography. It consists of a recording device, a cup in which the whole blood is kept, and a pin for measurement. There are two techniques: the thromboelastograph, that is the TEG, in which the cup is rotated around the fixed pin, and a rotation thromboelastometer, that is ROTEM, where the pin oscillates within the cup and it is used to measure the viscosity of the blood. The advantage of this is that we can measure the coagulation as well as the fibrinolysis being monitored simultaneously. The disadvantage of this method is that the cost of the equipment is extremely high and a poor reproducibility. That is, if you repeat the test, you may not get the same result. So this is what a thromboelastogram usually looks like. This is where the test is started. This is the time at which the test is started. In the initial phase, we have the reaction time. That is the estimate of the initial clot formation. That is the conversion of prothrombin to thrombin. The minute the prothrombin forms to thrombin, we have the next stage, that is the stage K, where we have the rapid clot formation where thrombin activates fibrinogen to form fibrin. The K and the alpha stages, that is the second and the third stage, estimate the rate of fibrin formation and the clot formation. So, and what we have after this, the level of MA is the maximum amplitude of the fibrin clot. That is the stage where there is a maximum concentration of fibrin and the maximum viscosity of the blood. After that, what we have is the activation of fibrinolysis, which is a prolonged phase, and it takes up to about 30 minutes, at which we measure the fibrinolysis for the next 30 minutes after the maximum amplitude of fibrinogen has been measured. Other viscoelastic assays, which we are not, which we'll just be mentioning since they are not in much of use, are the Rheorox assay, rheometry, and the turbidity and overall hemostasis potential, that is the OHP assay. This is a tabular format finally of all the tests which are used to monitor coagulation. The PT, APTT, thrombin time, activated clotting time, We also have bleeding time and clotting time, in which you can actually measure the platelet function and the platelet function in the blood. Thromboelastography again is more of a functional rather than a numerical, that is a quantitative analysis of the coagulation factors. We have measurement of fibrin degradation products, most commonly D-dimer, and the euglobulin lysis time, which are measurements of fibrinolysis rather than coagulation. Coming to coagulopathies, which is the second part of this lecture. Coagulopathy is defined as an impairment in the coagulation. It may be an excessive coagulant formation, which are defined as thrombophilias, or a decreased formation which causes an excessive bleeding, which are called bleeding diathesis. The most common presentations are enumerated over here. The most common presentation being excessive bruising or hematomas, hemarthrosis, which is bleeding into a joint cavity, postpartum or hemorrhage or menorrhagia, unexplained hemothorax, epistaxis, anal bleeding and urinary bleeding, that is hematuria, livido reticularis, which is bleeding into the skin, thrombocytopenia due to consumption of the platelets causing a functional thrombocytopenia, and gum bleeding, which is more commonly seen during brushing. We have types of coagulopathies which are inherited and acquired. The inherited are subdivided into the platelet disorders and the hemophilias, which we will be coming to now. Von Willebrand disease is the most common inherited bleeding diathesis. It can range from asymptomatic to severe uncontrolled bleeding. It depends on the level of functional von Willebrand factor circulating in the blood. We have three types of von Willebrand disease, and their transmission, and that all of them are a genetic transmission. The type 1 von Willebrand disease is an autosomal dominant transmission, which is almost 75% of the cases. And there is a quantitative deficiency of the factor. It can cause from mild to moderate bleeding. Type 2 is subdivided into four types, that is 2A, 2B, 2M, and 2N, in which we have varied qualitative defects. That is, the level of von Willebrand factor is normal, but the functional capability of this is defective. And it can lead again, it can vary from mild to life-threatening bleeding. And type 3 von Willebrand factor is an autosomal recessive type, which is a complete absence of von Willebrand factor, which can lead to severe bleeding even in case of minor traumas. We have a various number of tests for von Willebrand disease. First thing is a quantitative analysis of the von Willebrand factor itself. We have a ristocetin cofactor activity, factor 8 coagulant activity, since factor 8 is present in association with von Willebrand factor in the plasma. Hence, a factor 8 activity itself is reduced. We have a ristocetin induced platelet aggregation, in which we have a ristocetin cofactor, which is present in the blood. We measure the activity of this and inducing a platelet aggregation and clot formation by this cofactor. And we also have von Willebrand factor multimer distribution and binding assays of von Willebrand factor to the factor 8. The management of von Willebrand factor is to avoid NSAIDs and aspirin, since the most common presentation of von Willebrand disease is excessive bleeding following the first dosage with NSAID or aspirin. Otherwise, before that, the most common type 1 is seen, which does not cause much of bleeding. But once you take an NSAID or an aspirin, even these attenuated platelets are totally deactivated, and hence you can have bleeding. DDAVP, that is desmopressin, is more effective in type 1 von Willebrand disease and in mild to moderate bleeding symptoms. In cases of severe type 2 and type 3 disease, we have replacement therapy with von Willebrand factor and cryoprecipitate to tide over the blood loss, the bleeding. Coming to the next inherited disorder, we come to giant platelet disorders, which are characterized by thrombocytopenia, excessively large, that is giant platelets, and a variable bleeding symptoms. It has four subtypes: structural defect, which is Bernard-Soulier syndrome. We have abnormal neutrophil inclusions, which is the May-Heglen abnormality, and those with systemic manifestations, that is hereditary macrothrombocytopenia. The management of these giant platelet disorders is education of the patient and avoidance of minor trauma, platelet transfusion in case of major hemorrhage. These platelet disorders usually do not come into picture unless we are actually doing a blood test for something else or when a patient presents with bleeding. Otherwise, most of them usually remain asymptomatic. The next most common factor is Glanzmann's thromboasthenia, which is an autosomal recessive disorder in which there is a defect in the glycoprotein 2B3A. Now, this is a binding factor on the platelet membrane, uh, which causes which causes the attachment of the platelets to the damaged endothelium. However, due to the defect in this glycoprotein, they are unable to attach to each other. That is the next stage of the clot. That is the single layer of platelets is formed on the endothelium, but new platelets are unable to attach to the already activated platelets. Where we have learned of glycoprotein 2B3A in the monoclonal antibody abciximab. So this is where abciximab comes into factor in the antiplatelet activity. Now, a normal glycoprotein GP2B3A allows the activated platelets to adhere to each other. Now, once this does not happen, even von Willebrand factor and the further coagulation factors cannot be activated, and hence there is bleeding. Now we come to the next, that is storage pool disorders, that is deficiency of the platelet granules. Now platelet granules are divided into alpha granules and dense granules. The alpha granules contain von Willebrand factor, thrombospondin, fibrinogen and PDGF, which are all procoagulant. The dense granules contain ADP and serotonin, which are more of an anticoagulant activity, but also can be procoagulant by activation of the alpha granules. They are treated by platelet transfusions and pre-procedure desmopressin injections. In case of a dense granule deficiency, the only treatment is actually a bone marrow transplant in these cases. Coming to the hemophilias, which are defined as the deficiency of clotting factor, the coagulation factors. Now, actually speaking, hemophilias contain in layman's terms or in the basic terms, we only consider hemophilia A, that is factor 8 deficiency. Hemophilia B is factor 9 deficiency, and hemophilia C is factor 11 deficiency. However, a deficiency of any of the coagulation factors is grouped under the broad spectrum of hemophilias. These are the various factor deficiency and their various numerology. That is which is over here. Hemophilia A is an X-linked deficiency of specific factor 8. In case of divided into in case a level of up to 5 to 15% is more than enough of for the factor 8 to perform its activity. In case of severe less than 2% of normal levels, we have severe bleeding. In case the activity of or level of factor is 2 to 5%, we have moderate bleeding, and with factor level 5 to 30%, we have mild bleeding. But as up to 20% and above, we can have even a normal presentation with no bleeding disorder, with no bleeding presentation. Patient presents most commonly with large hematomas and hemarthrosis, that is bleeding into the joints, most commonly into the knee joint. Recurrent hemarthrosis causes joint damage and destruction by hemolysis, which is the second most common presentation of hemophilia A. Bleeding can last for hours and even up to days after injury, and there can be a delayed presentation in hemophilia A where the injury happens, where in the initial clotting factor, that is factor 8, is used up, where there is no bleeding, and once this is exhausted, then we start having a bleeding presentation. Intracranial hemorrhage is the most common cause of death in hemophilia A. If you do a lab test, you will have a prolonged APTT with a normal PT-INR, normal bleeding time, and normal von Willebrand factor levels. Instillation or injection of desmopressin may increase the levels of factor 8 transiently, but it is only to tide over the bleeding crisis. Antifibrinolytic agents such as tranexamic acid and E-aminocaproic acid are also used to manage hemophilia A. The management, that is the specific management for this, is cryoprecipitate and factor 8 concentrate transfusions. Hemophilia B is the X-linked, again, this is an X-linked disorder similar to hemophilia A, which is a deficiency of factor 9. It clinically cannot be distinguished from hemophilia A except in the fact that you will have a lab test which will show a normal factor 8 level. Other than that, all the tests will show the similar picture to hemophilia A. If you do a proper factor 9 assay, it will show a decreased level. A treatment is by prothrombin complex concentrate, which is a concentrate of factor 9 and other vitamin K dependent coagulation factors. And nowadays you also get specific factor 9 concentrate. What we need to know is patients who receive repeated levels of factor 8 and factor 9 transfusions may develop antibodies to these factors. Hence, what we have to use is recombinant factor 7A, which is available now, which is used to bypass the activity of factor 9 and factor 8, and direct factor 7A can be used in case of an emergency. Coming to the acquired coagulopathies, vitamin K deficiency is present in inadequate dietary intake, malabsorption, obstructive jaundice, biliary fistulas, and administration of long-standing TPN. It can also be seen in case of administration of vitamin K antagonists, that is acetrom or coumarin analogs, in which we have deficiency of factor 2, factor 7, 9, 10, protein C, and protein S. We have a prolonged prothrombin time with a normal to mildly raised APTT. The treatment is parenteral vitamin K in case it's not an emergency. That is, the vitamin K acts on into the production of these clotting factors in the liver, which take up to 6 to 8 hours for the action to begin. In case we need an immediate, that is in case of immediate or urgent management of severe bleeding, we can transfuse FFPs, and correction of the primarily etiology is a must in case of vitamin K deficiency. In case of liver hepatic insufficiency, all the clotting factors except 8 and 1 Willebrand factor are synthesized by the liver. Hence, in liver disease, it will evoke a global global insufficiency and decreased levels of almost all the clotting factors. It also causes thrombocytopenia due to portal hypertension, causing splenomegaly. Hence, we have the platelet part of the coagulation profile also being deranged in liver disease. The treatment for this is platelet transfusion, cryoprecipitate, fresh frozen plasma, and vitamin K injections. Hypothermia is seen during prolonged surgery, especially over the abdomen or thorax. It causes decrease in core temperature and defect in the platelet function, fibrinolysis, and it deactivates multiple coagulation factors, since most of these factors need a normal body temperature, that is from 37 to 38 degrees centigrade, to have their maximum action. And cases of massive transfusion, in which is defined as more than 10 units transfusion of PRBC or a total blood volume replacement within 24 hours. It presents as thrombocytopenia, low fibrinogen levels, and a prolonged prothrombin time. It can also cause a low body core temperature due to transfused blood, which can again trigger hypothermia-induced coagulopathies. Increased citrate level due to the storage, due to the PRBC preservative, hyperkalemia due to the lysed RBCs which have been stored. Low pH can cause a metabolic acidosis due to the lysis of RBCs and citrate, and hypocalcemia. The treatment of massive transfusion is actually, it is to more than a treatment, it is a prevention which needs to be infused at PRBC, platelets, and FFP in the ratio 1:1:1 to prevent a massive transfusion induced coagulation deficiency. Coming to disseminated intravascular coagulation, also called DIC, this is a systemic activation of the coagulation cascade which induce widespread thrombosis as well as hemorrhage. So this is actually a misnomer. It is a thrombosis, that is a coagulation which is activated due to a hemorrhagic factor. It is an initiating factor which is a tissue injury or an intravascular exposure to a coagulant in the setting of extreme inflammation. Hence, there is an overwhelming inactivation or the dysregulation of the inhibitory coagulation factors. Excessive thrombin production due to activation of both the intrinsic and the extrinsic pathways leads to large amounts of fibrin within the circulation. And what happens is, since there is no actual tissue damage or endothelium damage, this fibrin is released into the circulation. When it comes to the microvasculature, that is the arterioles and the capillaries, this fibrin cannot proceed through the capillaries and gets deposited into the microvasculature, which is the result of end organ damage, which is seen in DIC. A systemic thrombosis activates the tissue plasminogen activator, which causes thrombolysis. Now, this fibrin, which is deposited in the corner in the end organs, activates TPA, which again causes thrombolysis, consumptive coagulopathy, and bleeding. Since there is thrombolysis forming, but the procoagulant state is still ongoing, what happens is the coagulation factors get consumed by the overwhelming coagulative state, and hence when there is actual this is unable to stop bleeding at other sites in the body, like the gums and various orifices like the bleeding gums, rectal and urinary tract. The stages of DIC: phase 1, in which there is a compensated activation of the hemostatic system. The patients are usually asymptomatic, but end organ damage has begun. Phase 2, in which there is decompensation of the hemostatic system, in which there is overwhelming hemorrhage. That is, all the coagulation factors have been consumed, and now there is hemorrhage from the injuries, vein puncture sites, and from the various body orifices. There is impaired renal, hepatic, and pulmonary function due to end organ damage, which is caused by the fibrin depositing into the end arteries. And phase 3 is complete DIC, in which is a positive, where the patients have numerous and multiple ecchymosis and multi-organ failure. Lab tests show consumptive coagulopathy, and unless we have replacement of the coagulation factors, the patient is going to go into systemic multi-organ failure and death. The patient is managed by correction of the precipitating disease and the inflammatory process. Supportive care is the replacement of clotting factors and maintaining normothermia so that the coagulation factors are at maximum efficacy. In patients with active bleeding, we have aggressive replacement of the clotting factors is required in the form of cryoprecipitate, fresh frozen plasma, or even specific clotting factor, coagulation factor transfusion. The goal of the resuscitation should include a fibrinogen level of over 100 milligrams per deciliter. In cases of severe sepsis, broad spectrum antibiotics and source control, that is form of debridements or amputations, is critical. I've come to the end of my presentation. Thank you.